Hello, everyone. I would like to welcome you to the 9th CLL Care webinar, what is an educational program for HCPs worldwide. This program aims to provide hematologists with a comprehensive understanding of the latest development in CLL management. Today, it's my pleasure to welcome Professor Stephan Stilgenbauer, Associate Professor at University and Director of the Comprehensive Cancer Center Professor Stilgenbauer is a leading expert in chronic lymphocytic leukemia and lymphoma, recognized globally as one of the highly cited researchers. His work focuses on the personalized tumor therapy and translating research findings into the clinical practice. Today, he will be presenting finite therapy in CLL, practical guidelines on patient selection, treatment planning, and clinical application. During the webinar, please mute yourself and silence your devices, and I encourage you to ask questions through the session in chat box. And now I'm pleased to hand the floor over to Professor Stilgenbauer.
Hello and welcome everybody. My name is Stephan Stilgenbauer, as introduced, and it is a great pleasure to talk to you today about the topic of finite treatment duration and the schedules that we have available to treat patients with CLL with these regimens. So the objectives of this webinar are firstly to understand the rationale and benefits of finite treatment duration regimens. Secondly, to review key finite therapy regimens, the data and the clinical applications. Thirdly, to explore the role of minimal residual disease in future treatment directions. And fourth, to provide practical guidance on patient selection and management of finite therapy regimens. So the evolving landscape of CLL treatment is very nicely illustrated by this cartoon. At the very top, you see that in the 90s we had chemotherapy, then we evolved over chemoimmunotherapy, finally to targeted therapy, which has been the leading treatment paradigm for now up to 10 years. The treatment principles that we have available are targeting biologically very relevant molecules such as Bruton tyrosine kinase, BTK, or the BCL2 molecule involved in the apoptosis cascade. The progress that we have made with these regimens is illustrated in the survival curves at the bottom, where you see overall survival of patients broken down into the CLIPI risk groups on the left, with the survival times with chemoimmunotherapy regimens, and on the right, what we have now witnessed with regard to targeted therapies. And you see that yes, there is still some prognostic impact of the CLIPI with the separation of the survival curves, but the survival times have much improved, in particular for the high-risk subgroups in the CLIPI shown in purple and in red. So what are the regimens that we have available, and what are the pros and cons of these? Well, the one treatment paradigm is continuous monotherapy with a BTK inhibitor, as illustrated on the left, with the pros of long-term disease control, all oral therapy, and efficacy also in high-risk groups defined by 17p deletion and/or TP53 mutation. On the right, we have the regimens of fixed duration, which are based on BCL2 inhibitors such as venetoclax, either combined with a CD20 antibody such as obinutuzumab, or with BTK inhibitors such as ibrutinib or acalabrutinib. Less preferred today, obviously, chemoimmunotherapy. These regimens have, due to the limited duration, limited time of adverse events, likely lead to reduced clonal evolution and resistance, and obviously due to the shorter treatment duration could be associated with decreased financial burden for patient and the healthcare systems. Now, looking a bit more into detail, comparing these treatment paradigms of, in this table on the left, continuous treatment or time to treatment to progression, and fixed duration treatments as shown on the right, what are the options? As I said, BTK inhibitor, covalent BTK inhibitors such as acalabrutinib, zanubrutinib, or ibrutinib, with or without CD20 antibody, versus venetoclax-based combined with a CD20 antibody and/or a BTK inhibitor are the options. The advantages of continuous BTK inhibitors are obviously effective disease control over long periods of time, while the advantages of fixed duration are the treatment-free intervals that are based on deep responses that are achieved due to the fact that we get patients into undetectable MRD residual disease states with these treatments, and the avoidance of cumulative toxicity with these regimens over time. The disadvantages, therefore, of continuous therapy are these very long treatments. MRD negativity cannot be achieved with those, and the potential for development of resistance mutations. While with fixed duration treatment regimens, the disadvantages are that the disease will recur in many of those patients after a treatment-free interval, and that it may not be the ideal treatment for the very high-risk patients defined with a 17p deletion. Now, all in all, we have to find a balance when summarizing all efficacy parameters such as progression-free survival, time to next treatment, and overall survival, and balance those against the burden of adverse events, duration of adverse events, and severity of adverse events that we experience with those treatments. Factors driving our treatment choice between these treatment paradigms are obviously, firstly, patient preference, but also the genomic disease profile, specific comorbidities, quality of life aspects, patient comorbidities and age, and access as well as logistical issues of these treatments. Now, a suggested frontline treatment algorithm according to genetic disease subgroups has been put forward in last year's ASH Educational that we were honored to give. And this algorithm clearly stratifies patients by genetic disease parameters. At the very top of this cartoon, you see that the watch and wait treatment paradigm is obviously still in place for asymptomatic early stage patients that do not meet the active disease criteria put forward in the IWCLL criteria. Only when these active disease criteria as indications for treatment are met, relevant questions with regard to genetic disease characteristics arise. As you see in the red boxes, the first important distinction is between the presence and absence of 17p deletion and/or TP53 mutation. When we go to the left part of the cartoon, when there is absence of 17p deletion and/or TP53 mutation, the second important question is if there is mutated or unmutated IGHV genes. And when we again go to the left, among the patients with mutated IGHV, so with a very good prognosis, the preferred treatment paradigms clearly were obinutuzumab plus venetoclax or ibrutinib plus venetoclax, or acalabrutinib combined with venetoclax, which has recently been licensed as a novel treatment option. Only secondary options are the continuous BTK inhibitor treatments based on acalabrutinib or zanubrutinib or ibrutinib. And when focusing on the middle among the patients with unmutated IGHV, all the options of time-limited but also of continuous therapy are equally valid, and more the preference goes to time-limited treatments that are either obinutuzumab plus venetoclax or ibrutinib plus venetoclax, or more recently licensed acalabrutinib plus venetoclax, which are preferred more and more over an equally valid option of continuous BTK inhibitor therapy. Only for patients with presence of a 17p deletion and or TP53 mutation, the group on the very right here, we still prefer continuous BTK inhibitor monotherapy, either with acalabrutinib or with zanubrutinib as the preferred treatment paradigm. Now, next to these genetic disease characteristics that stratify our patients, the other important factor is obviously not only patient preference, but also patient characteristics such as comorbidities and logistic issues. And to implement this into the paradigm, we have developed this heat map in this educational, where not only the genetic characteristics are being looked at, but also in this color code of green, very preferred, to red, less preferred, the various factors such as treatment logistics, adverse events, comorbidities, and co-medications that come into play. Now you can look at this cartoon as it is published in writing, but just to briefly illustrate it, when looking at the middle columns here, the treatment-related logistics, obviously the option of finite treatment duration is not offered by the continuous BTK inhibitor monotherapy options such as ibrutinib, acalabrutinib, or zanubrutinib, but only by the combination regimens of obinutuzumab plus venetoclax, ibrutinib plus venetoclax, or more lately acalabrutinib plus venetoclax. On the other hand, treatment initiation with these time-limited regimens is a bit more cumbersome. There are infusion-related reactions with the antibodies, and there is tumor lysis syndrome prophylaxis and management needed with these venetoclax-associated treatments. On the right of this cartoon, you see the matrix of adverse events, comorbidities, and co-medications that also drive our treatment decisions here. Obviously, with the continuous therapies with BTK inhibitors given at the top, we have an accumulation of adverse events over time, and we have a somewhat higher bleeding risk. While the TLS risk is in particular with the venetoclax-based regimens, cardiovascular disease profiles again drive our treatment decision probably a bit away from continuous BTK inhibitor monotherapy, but also from combined regimens using BTK inhibitor plus venetoclax, while reduced renal function is a factor that is somewhat an argument against venetoclax-based treatment, and the infection risk obviously is something that is greater with addition of CD20 antibodies. So a complex matrix is arising where, sure, for patients with mutated IGHV, on the very left, we prefer time-limited venetoclax-based treatments, while for patients with a 17p deletion, we prefer continuous BTK inhibitor monotherapy, while for patients with unmutated IGHV, all of these options are equally valid. However, our individual treatment decision is much influenced also by the characteristics shown on the right of this cartoon, patient-specific coexisting conditions, co-medications, and logistical issues. Now, what are the drugs that we have available? What is the licensing status in the US and in the EU for these agents? Ibrutinib is approved in the US and also in the EU as continuous monotherapy, but in the EU also when combined with venetoclax as a time-limited treatment. Acalabrutinib as monotherapy is also licensed in the US and in the EU. In the EU, also the combination with venetoclax as a time-limited treatment approach is licensed, which is still under assessment by the FDA in the US and likely be licensed in the near future. Zanubrutinib as a monotherapy is approved in the EU and in the US and investigated as a combination treatment with BCL2 inhibitors. Now, pirtobrutinib is licensed as a monotherapy continuously in the US and in the EU, but only in the relapsed refractory setting, while the above options are available for frontline treatment. Nemtabrutinib is a second non-covalent BTK inhibitor that is currently still investigational and studied in clinical trials. Now, the treatment paradigm of time-limited treatment versus continuous BTK inhibitor monotherapy can be put in a kind of head-to-head comparison of the data that we have available from various clinical trials. Obviously, we do not have head-to-head comparisons of these paradigms available from randomized trials, but we can lay the data side by side from various individual trials. And what we did here in this also cartoon from the ASH Educational is show that with continuous BTK inhibitor monotherapy at the very top for all patients, so the aggregate of all patients, we probably achieve a 9 to 10 year period until treatment failure of this class of agents is reached for our patients. Now, with a 1 year treatment duration of BCL2 inhibitor-based combination treatment, probably we achieve a somewhat shorter period of first response, as indicated by the light blue arrow, but then we can retreat with a BCL2 inhibitor-based regimen, leading also to very good long-term outcomes. Now, at the bottom part of this cartoon, the situation differs a little bit between the genetic subgroups, where you see that among the 17p deletion and or TP53 deletion patients, probably outcome is worst with a BCL2 inhibitor-based regimen. it is probably very comparable for patients with unmutated IgHV, and it is preferably influenced with mutated IgHV for BCL2 inhibitor-based treatment. Now, what are the regimens that we have available with regard to fixed duration therapy of CLL? One of them is the combination of BCL2 inhibitors with CD20 antibodies, and here we have data from the Gaia CLL13 trial for young patients and from the CLL14 trial for elderly patients. And in both trials, high MRD undetectable rates and long progression-free survival or overall survival in the range of 80 to 90% at 4 to 5 years were achieved. This is the data from the CLL13 Gaia trial, at the top for unmutated IgHV, at the bottom for mutated IgHV. You see with this 1 year fixed duration treatment regimen, a very good long-term disease control with the venetoclax obinutuzumab regimen shown in red here in these curves. And you see a little bit of a difference with longer progression-free survival times across all treatment regimens, actually at the bottom with the mutated IgHV patients. So there is a prognostic impact, nevertheless, also for patients with unmutated IgHV. The outcome with venetoclax obinutuzumab, as shown in the red curve in the top cartoon, is very good. Now, with regard to the elderly patients, we have data with mature follow-up from the CLL14 trial. Here you see in the blue curve venetoclax obinutuzumab, where at 6 years of median follow-up, the PFS rate with venetoclax obinutuzumab is 53.1%, i.e. at 6 years of follow-up, the median PFS is not reached after only a 1-year treatment duration. And also the time to next treatment, which is a very important endpoint, obviously, for patients, is 65% with venetoclax obinutuzumab at the 6-year follow-up, i.e. 2/3 of patients did not need retreatment at 6 years of follow-up with this regimen, which is a very valuable outcome for our patients. Now, undetectable minimal residual disease is an important prognostic marker, and patients reaching undetectable minimal residual disease have better outcomes with these treatments as patients where minimal residual disease remains detectable, as evidenced in these cartoons, with a much higher undetectable minimal residual disease rate with venetoclax obinutuzumab as compared to chlorambucil combined with obinutuzumab. Now, with regard to safety and adverse events, sure, during the early combined treatment phase, the majority of patients treated with venetoclax obinutuzumab have and experience adverse events. However, in the time of therapy, and this data is summarized at the table at the top on the left, during the time of therapy, obviously, there is a very, very low rate of adverse events in this treatment-free interval, which is obviously clearly demonstrating the benefit of time-limited treatments. Now, what is the rationale for combining BTK and BCL2 inhibitors? Well, most of that is coming from the point that both of these classes of agents are obviously very efficacious, and combining these two treatment paradigms into a single regimen obviously appear to be very promising. There are other biological bases that may underlie this combined and probably synergistic efficacy of these agents that I do not want to go into detail here further. However, what we do have is evidence from the combination of these two treatment classes that efficacy is indeed very good. And this is the evidence from the first generation BTKI ibrutinib when combined with venetoclax. Here we have data from large trials such as Captivate, a phase 2 trial, and GLOW, a phase 3 trial, that also high rates of undetectable MRD can be achieved, and very favorable 5-year PFS rates and overall survival rates, again in the range of 80 to 90%, depending on the patient subgroup studied. Now, what are the data here? This is the GLOW trial with mature follow-up, comparison in the frontline setting of obinutuzumab chlorambucil versus ibrutinib plus venetoclax. On the left, you see progression-free survival with a clearly superiority of ibrutinib plus venetoclax. And at 5.5 years of follow-up, you see that median progression-free survival with ibrutinib plus venetoclax here is not reached. So patients have more than 4 years of therapy without reaching this median PFS. On the right, you see that ibrutinib venetoclax is also associated with an impact on overall survival as compared to chlorambucil obinutuzumab, resulting into a long-term benefit for our patients. Now, this is an important cartoon looking at the time perspectives of grade 3 and 4 adverse events with the two treatments. And on the left, you see the data for ibrutinib plus venetoclax from the trial with this green area in that curve of the proportion of grade 3, 4 treatment at emergent adverse event-free, progression-free survival time, which is obviously very extensive due to the long responses and time of therapy that these patients achieve, and looks much beneficial as compared to chlorambucil plus obinutuzumab, mostly due to the better efficacy, but also due to the good tolerability of the I+V regimen. Now, the other data set that we have available is for young patients. From the Captivate trial, a single-arm trial, here looking in particular at the fixed duration regimen, again of 3 cycles of ibrutinib lead-in and 12 cycles of combined treatment. Here we have very good outcome data as evidenced for progression-free survival on the left and overall survival on the right, with PFS rates a little bit different between unmutated and mutated IGHV, but still very good outcomes for both subgroups. In particular, when looking at the right part of this slide here, where overall survival for both subgroups is more than 90% at a 6-year follow-up with this regimen, which obviously indicates very good long-term outcomes for our patients with this treatment. Now, this is the adverse event experience with these treatments. You see on the left data from GLOW with a median age of 71 years, on the right from Captivate with a median age of 60 years. With in both cohorts, neutropenia was the most common grade 3 and higher adverse events. However, infections were more common in the elderly patients, as was atrial fibrillation or flutter and cardiac events overall, which led to a safety signal in the elderly population of the GLOW trial with this ibrutinib plus venetoclax combination, while in the trial for younger patients in Captivate, fortunately so, there was only 1 death possibly attributable to ibrutinib-associated cardiac events among 159 patients in this population. Now, what are the next regimens that are possibly coming down the road in ongoing trials investigating BTK inhibitors plus BCL2 inhibitors? Well, this is the CLL17 trial comparing ibrutinib against obinutuzumab plus venetoclax against ibrutinib plus venetoclax, with data hopefully to be seen at ASH this year. It is CLL16 comparing venetoclax obinutuzumab against the same regimen with the addition of acalabrutinib. It is the MAGIC trial that compares obinutuzumab against acalabrutinib plus venetoclax in an MRD-guided setting, and the ECOG-ACRIN trial comparing ibrutinib obinutuzumab against the same regimen plus venetoclax. Phase 3 data that we have already available come from the FLAIR trial that compares FCR against ibrutinib or ibrutinib plus venetoclax, and importantly so, the AMPLIFY trial that tested acalabrutinib-based time-limited combinations with venetoclax with or without obinutuzumab against chemoimmunotherapy. And we will look into data of these trials now. Now, this is the FLAIR trial that clearly showed improvement in progression-free survival, but also in overall survival with an MRD-guided ibrutinib plus venetoclax regimen over notably fludarabine, cyclophosphamide, and rituximab FCR, the most efficacious chemoimmunotherapy regimen. Obviously, this was a trial for young and fit patients and resulted in very favorable outcome. Nevertheless, the MRD-guided ibrutinib plus venetoclax treatment duration as used in FLAIR is not actually licensed explicitly in the EU, and based on the MRD-guided treatment led to prolonged treatment durations with I plus V. The average of patients needed about 3 years of treatment, and about 20% of patients were still on I plus V treatment after 5 years, clearly indicating that this prolongation of treatment may also be associated with an increased rate of adverse event. Now, the other data set that we have available with regard to further improving our treatment options is from the AMPLIFY trial, an important, large, 3-arm randomized trial that compared among young and fit patients either FCR or BR as the standard chemoimmunotherapy arm against acalabrutinib plus venetoclax, the AV regimen, or the same regimen with the additional administration of obinutuzumab CD20 antibody. Now, here is the primary endpoint of this trial. Acalabrutinib plus venetoclax and acalabrutinib plus venetoclax plus obinutuzumab, the AVO regimen, both led to improved progression-free survival with these time-limited treatment approaches as compared to chemoimmunotherapy in this trial, with a slight improvement, as you can see in this graph here, with the addition of obinutuzumab to AV, although the trial did not have the primary aim to compare these two treatments. Nevertheless, superiority of the AV and AVO regimen as compared to chemoimmunotherapy, clearly establishing with AV and AVO another valuable treatment paradigm. Now, with regard to genetic subgroups, as broken down here, you see that unmutated and mutated IGHV impacted outcome mostly with chemoimmunotherapy, and the outcome of the unmutated IGHV subgroup was particularly improved with the triplet combination of acalabrutinib, venetoclax, and obinutuzumab, the AVO regimen. So therefore, patients with unmutated IGHV may be particularly good candidates for this triplet treatment regimen. Now, with regard to overall survival, we do see an improvement with AV over chemoimmunotherapy that we do not see with a triplet regimen. However, we need to take into consideration that this trial was conducted during the COVID pandemic, and the addition of the antibody led to an increased number of COVID-related deaths in the AVO arm that clearly harmed this trial, particularly with regard to its overall survival outcome. Nevertheless, it alerts us to the fact that with addition of the antibody, we need to be aware of an increased infection risk among our patients, and next to unmutated IGHV, therefore, obviously, patients with a history of infections should probably be only carefully considered for this treatment option, and young and fit patients without a history of infections appear to be prime candidates for this treatment option. Now, speaking of adverse events, this is the table of adverse events from the trial, comparing the 3 arms, and then all grade toxicity again, and grade 3 and higher toxicity. You see that in all arms, the most common higher grade toxicity was neutropenia. That was not much different, slightly increased with the addition of obinutuzumab. Febrile neutropenia was fortunately very rare, indicating that these treatments can be administered safely. However, the overall infection rate, grade 3 and higher, was about 12% with AV and 24% with AVO, so a doubling of grade 3 and higher infections, again indicating that we need to be aware of infection risk when adding an antibody to the AV regimen. Overall, however, this slide indicates a very favorable safety profile of the AV and AVO regimens, with most grade 3 and higher toxicity being in the single-digit % range, showing that this is a very tolerable regimen for our patients and better suited for most of them than chemoimmunotherapy. Now, what about minimal residual disease assessment? This is obviously a very interesting topic, possibly allowing for even better treatment guidance and treatment adjustments in the future. Now, MRD assessment allows obviously a very objective way of measuring residual disease in peripheral blood and in bone marrow of our patients. And it has been shown with chemoimmunotherapy regimens, but also with targeted time-limited treatments, that it is a valuable surrogate endpoint for progression-free survival and possibly also overall survival. Now, undetectable minimal residual disease is of prognostic value, particularly in BCL2 inhibitor plus CD20 antibody combinations, as shown in CLL14. And MRD-guided treatment shows promising efficacy, as I've illustrated to you, in particular in the FLAIR trial. However, further work needs to be done to show that this treatment approach is indeed superior to fixed duration treatment options that we have available, for instance, with obinutuzumab plus venetoclax, or with ibrutinib plus venetoclax, or acalabrutinib plus venetoclax, which are all licensed in the EU in a time-limited fixed duration regimen. Now, what does the data look like with regard to the prognostic impact? Here you see data from CLL14 for venetoclax plus obinutuzumab. On the left, a landmark analysis for PFS, on the right for OS, where you see that patients not achieving MRD negativity as with the 10 to the power of 4 cut point clearly have a much inferior outcome as compared to patients who do achieve such a negative minimal residual disease states. So there is prognostic impact of this parameter. Furthermore, there is a meta-analysis of first-line trials from the past available that again clearly indicates that with targeted therapy as well as with chemoimmunotherapy, achieving undetectable minimal residual disease matters. On the right, however, you see that with targeted therapy, the impact of minimal residual disease possibly is somewhat diminished as compared to the era of chemoimmunotherapy, where clearly patients with detectable minimal residual disease had very inferior outcomes. Now, with regard to conclusions on these fixed duration treatment regimens that we have available for our patients with CLL, these regimens have become practice-changing approaches for managing our patients with CLL. In particular, the combination of BTK inhibitors with BCL2 inhibitors provide deep and prolonged disease control, leading to improved outcomes, also among patients with unfavorable prognostic features such as unmutated IGHV. Now, second-generation BTK inhibitors such as acalabrutinib or zanubrutinib have, in the relapsed refractory setting as monotherapy in head-to-head studies, shown at least equivalent efficacy and improved tolerability. Therefore, these are the preferred treatment options that we have available with regard to continuous BTK inhibitor monotherapy today. The combination of second-generation BTK inhibitors with BCL2 inhibitors with and without CD20 antibodies obviously extends the benefits of all oral finite treatment durations to a broader range of CLL patients. And further clinical trials are needed to look deeper into the value of MRD-guided treatment strategies for our patients with the aim of further improving their outcomes. Now, what are the future directions that we have, and what are the key questions that we have to address in this precision medicine kind of treatment approach? Now, with regard to the diagnostics and prognostication, currently we use IGHV status, TP53 mutation, and deletion 17p for treatment selection. However, in the future, tailoring of treatment may be further improved based on comprehensive genomic profiling. With regard to precision therapy, today we have continuous BTK inhibitor monotherapy and fixed duration regimens, as I have outlined, as treatment standards that are much superior to the chemoimmunotherapy approaches that we have used in the past. Now, in the future, the aim is obviously to further refine our stratification to administer the right drug at the right time to the right patient to further improve outcomes. And with regard to precision disease monitoring. Currently, we have clearly data that MRD monitoring is very valuable as an additional endpoint in clinical trials and is of prognostic value, while in the future we hope that MRD monitoring may further improve to guide treatment with regard to early cessation or possibly intensification for further improvement in outcome of our patients. Now, with regard to this background, what about the patient selection for finite therapy and practical considerations? And here we have a case that I would like to discuss with you, a case that has been developed to most typically present the patients that we see in our clinic today and that is representative for the challenges that we face in our everyday practice. Now, this is a 72-year-old male. A CLL was diagnosed 3 years ago in a health checkup. Now, today in your clinic, this patient presents with worsening fatigue. His past medical history is remarkable for unstable angina. He had stent placement 2 years ago, has some hypertension, hyperlipidemia, and COPD, but all these conditions are well controlled and he is free of any complaints at the current time point. His medication involves aspirin, beta blocker, sartan, statin, and anti-obstructive dual bronchodilator therapy, and he lives with his wife with a 30-minute drive to your clinic. With regard to prognostic marker assessment, he's characterized by unmutated IGHV and 13q deletion only, so there is no TP53 mutation and no 17p deletion. Upon physical exam, you find ubiquitous lymphadenopathy up to 4 centimeters in diameter, and the spleen is palpable 5 centimeters below the costal margin upon inspiration. With regard to the labs, you find progressive lymphocytosis of 89,000. There is anemia with 10.7 grams per deciliter and thrombocytopenia with 104,000. His renal function is slightly reduced with a creatinine clearance of 63, and his SEER score due to the comorbidities is increased to 6. Now, based on IWCLL criteria, there is indication for treatment. He has complaints with worsening fatigue. There is anemia and thrombocytopenia, just slightly not reaching the Binet stage C characteristics, but still clear indication for treatment, also based on the progressive organomegaly that is seen. Now, against this background of this elderly gentleman who is pretty fit, has some reduced renal function, some cardiac history, IGHV unmutated CLL with 13q deletion, but without TP53 mutation or 17p deletion, we need to consider what our best treatment options are and what your preference for treatment could be. And therefore, here we have the first polling question, where we would like to get your feedback and gauge your opinion. What would be your preferred treatment choice for this patient if you had him in your clinic today? Is it continuous BTK inhibitor with acalabrutinib, ibrutinib, or zanubrutinib, the option of your choice? Is it finite duration venetoclax plus BTK inhibitor? So either venetoclax combined with acalabrutinib or ibrutinib as licensed in the EU? Or is it finite duration venetoclax plus obinutuzumab, the other time-limited treatment option that we have available? Or is it chemoimmunotherapy? Please make your choice now and give us your response. So here we have the result. The majority of you chose finite duration treatment option with a BTK inhibitor and a venetoclax, so acalabrutinib plus venetoclax or ibrutinib plus venetoclax, while about a good third chose finite duration treatment with venetoclax obinutuzumab. I'm very happy to see that many of you clearly have a preference for a time-limited treatment option. There's a bit of a split between either combining venetoclax with an antibody or with a BTK inhibitor, which I think is understandable in that case. Nevertheless, I think also continuous BTK inhibitor monotherapy may still be an option in this patient. Because there is some reduced renal function, there is some comorbidities that make these options also available. But personally, to me, indeed, I have to say a patient of this kind may benefit very much from the time-limited combination options that we have available, and in particular because he may enjoy long treatment-free intervals after such time-limited treatment options. And as I've shown, you also a long treatment-free interval, which is obviously very favorable. Now, the second polling question, to go a bit more into detail here, is given your treatment choice, what are the characteristics that make you choose your option, given the patient's comorbidities, coexisting conditions, and co-medications, and the disease characteristics? What did influence your treatment choice here most? Is it the coronary artery disease and stenting history? Is it the hypertension? Is it the COPD? Or is it the reduced renal function? What drives your treatment decision most? Please give us your opinion now. Okay, here we have the feedback, very important. I think nobody of you was worried very much about the COPD, which is well controlled, usually not a treatment guiding factor indeed with the treatments that we have available. The coronary artery disease or the heart disease was driving the treatment decision for the majority of you, and I would agree that obviously we are worried of cardiac events because those can be cumbersome and dangerous for the patient, and obviously need to be looked at in good detail. Also, hypertension was selected by some of you as the driving force, which clearly is related also to cardiac events, but also cardiovascular events such as stroke, and need to be managed well. And some others decided based on creatinine clearance, which is also very valid because the renal function is obviously very important, in particular with regard to treatment and administration with venetoclax, but also with regard to overall health outcome, because all conditions, in particular when we also think about infection management, are much influenced by the renal function of a patient, and renal function need to be taken care to be managed well and to be preserved for not risking harmful effects on longer term outcomes. So I very much agree with your prioritization of coexisting conditions with regard to treatment decisions here. And with this, we come close to the end and look again at the pros and cons of continuous BTK inhibitor therapy and fixed duration BCL2 based regimens, where the pros of continuous BTKIs may be in the ease of treatment and administration, in particular in patients with a high tumor load and somewhat reduced renal function as seen in this patient, and obviously the ease of initiation of therapy. While the pros of the fixed duration treatments are that the cardiac comorbidity of the patient is not so much of influence, hypertension may not evolve so much over time, and the prospect of treatment-free years. The cons of continuous BTK inhibitor in the patient would have been obviously the continuous treatment and also cost burden, while the con of the fixed duration treatment clearly is the somewhat more complex treatment start with management of hemolysis syndrome, and in the case of co-administration of an antibody, also the infusion-related reactions. Now, with regard to answering this question more definitively, we can look forward to future meetings, possibly ASH this year, where data from the CLL17 trial, which compared ibrutinib against fixed duration venetoclax plus ibrutinib against fixed duration venetoclax plus obinutuzumab data may be presented to help us get a better evidence base to make our treatment decisions of this kind. And with this, we're at the end. I thank you very much for your attendance, and I'm looking forward very much to discussing questions that you may have submitted in the chat. Thank you.
Okay, so thank you very much for this insightful presentation. So how Professor Stilgenbauer mentioned, now we can start with Q&A session. So please, if you have any question, write to the chat and Professor Stilgenbauer will answer. But in meantime, I get one question, but on the team, so it's not here. So I will ask it. So the question is, MRD negativity is less durable in a high-risk TP53 patient. Would you still consider a fixed duration therapy in those patients?
Right. So patients with CLL or with a 17p deletion and or with a TP53 mutation have a somewhat inferior outcome, not only with regard to MRD, but also with regard to PFS and probably OS with time-limited treatments. So with obinutuzumab, venetoclax, and ibrutinib plus venetoclax. We have the strongest evidence here with obinutuzumab, venetoclax due to the longer follow-up. Nevertheless, I think a time-limited treatment, in particular with acalabrutinib, venetoclax, or ibrutinib plus venetoclax, may still be a valid treatment option also for patients with a 17p deletion, in particular if they have, severe cardiac coexisting conditions that make you shy away from a continuous BTK inhibitor or are on combined anticoagulation and antiplatelet drugs that make you have a fear of bleeding events. So I think, yes, overall, we prefer continuous BTK inhibitor monotherapy with acalabrutinib or zanubrutinib in patients with a 17p deletion and or a TP53 mutation. However, if coexisting conditions or also patient preference are more in favor of a time-limited treatment, this is still a valuable treatment option for these patients.
Okay, thank you very much for the answer. And we have another question is, so the first is, does deletion 70P or TP53 need continuous treatment?
Yeah, so I think we touched upon this a little bit, or I tried to in my first answer. As I said, in summary, 17p deletion TP53 mutation defines a patient subgroup where we prefer continuous BTK inhibitor monotherapy. Nevertheless, if there are good reasons against delivering continuous monotherapy, the options of time-limited treatment are also valid, and this needs to be balanced, efficacy and tolerability, to make to create most benefit for our patients.
Okay, thank you. Then we have another one. Any concern about the low rate of MRD with AV? Should we prefer EV for this reason?
Yeah, this is a very important, obviously expert question here. In the Amplify trial with AV, we have seen somewhat lower MRD undetectable rates as compared in a cross-trial comparison with IV in Captivate or in GLOW. Now, the reasons may be multiple. As I said, Amplify was much hurt by the COVID pandemic with missed visits and other issues. On the other hand, there is the data as it is, which may indicate that I plus V could have a somewhat better efficacy, a somewhat better MRD undetectable rate. But on the other hand, we have the evidence that acalabrutinib is a better tolerated BTK inhibitor as compared to ibrutinib, at least in the monotherapy setting, that again would favor the AV combination over IV. So what we would need to definitely answer that question is obviously a randomized comparison of the two regimens, which likely will not be available. However, a longer follow-up of AV will show if these lower MRD undetectable rates truly translate into less favorable long-term outcome. And I think we have to await these longer-term follow-up data before we can give definitive answers on this question.
Okay, thank you for your answer again. And we have another question. So, how would you approach a younger patient with adverse genetic TP53 mutation, ULGHV, and complex karyotype? Would you go for final therapy treatment in these scenarios where treatment sequence is key, assuming no trials are available?
Yeah, thank you again to the participant for giving me this challenging task. Obviously, young patients with these clear adverse prognostic markers are, the true challenge in our practice, because for young patients, we want to achieve good long-term outcomes, many years where the disease is under control. And this is particularly difficult with these adverse markers. Probably in such a patient, indeed, I would prefer continuous BTK inhibitor monotherapy, clearly aware still of the fact that the disease may relapse during his or her lifetime, and salvage treatment may be needed. However, I'd hope that when at relapse, delivering a venetoclax-based time-limited approach, i.e. combined with a antibody, we still may achieve a response, and that still then probably young patient, could be transferred to possibly a transplant, an allogeneic transplant, or CAR T-cell treatment with that response to again achieve good outcome. Furthermore, we obviously do hope that for these young patients, in about 5, possibly 10 years' time, if we gain that time with our treatment approach, we have additional new treatment approaches available, such as, for instance, BTK degraders, bispecific antibodies, or other CAR T-cell based approaches that will help, in particular, those patients also in the future.
Okay, thank you very much. I think we have time for last question. So if somebody from attendee would like to ask, there is the time now. Okay, probably that's it. So thank you very much again, and we sincerely appreciate your contribution to this program. And I would also like to inform everyone here that the recording will be available in our platform and also on the Spotify. So thank you very much for this webinar.
I thank you for having me. Thank you for the discussion. And my bottom line here is we have great treatment options for our patients. Time-limited treatments offer time off therapy, and for most patients are a very good treatment option. And I'm looking forward to future discussions with all of you on this topic. Thank you very much.